start in 3, 2, 1. We are live, sir. Please start.
All right. Good evening, everyone. All those who have joined on the web stream program, as well as those who have joined the Zoom meeting with us, the dignitaries, all the faculty, welcome to this fourth webinar, or what used to start as seminar. We used to do on WhatsApp, and then we moved gradually during COVID time to this Zoom meeting and started doing webinar. And we have done 3 so far. First was the labs in hematology, then back-to-back 2 were on tuberculosis, and now this was on a very important subject of when the child has a joint pain and leg pains. So first of all, I'd like to thank Zydus for providing this platform yet again. And let me share my screen. I just want to, yes. So you are able to see my screen, right?
Yes, sir.
So you can see the first webinar which we did on the hematology already has more than 1,500 views. Then with the first on the TB on 11th April has more than 1,000 views. And the second one on the therapeutics of the TB is just picking up with 500 views. So a lot of people actually may not see live today and actually will go back and see at leisure from their home. So we encourage this, and all these telecasts which are live today are actually recorded and then put on this Gujarat Pediatrician group. So on YouTube, you can find this Gujarat Pediatrician group. You can subscribe to it, and automatically you will get a pin whenever a new video is put, and you can visit this Gujarat Pediatrician freely and see any of these webinars which have been done in the past. And the next one, before we start today's one, I thought I will first introduce is on the 6th of June, first Thursday of June. Again, same time, 9 p.m. to 10:30 p.m. And it says call the shots. So it's going to be on the vaccines, something which is very, very specific and very, very near to the pediatrician, because today in pediatrics, one of the most important practice that remains is vaccination of the children. Today we have joint is angry, so it's not only on the JIA, but we will also discuss non-JIA joint problems. And I have made a PowerPoint of 9 cases, and I'm sure you will enjoy these cases. We have Dr. Ramesh Bajania, who is from Surendranagar and is also the admin of the Gujarat WhatsApp group, Pediatrician WhatsApp group. So we will be two together moderating this session, and we have an extremely allied panel in the form of Dr. Surjit Singh, who is like the father of rheumatology, immunology, and immunodeficiency. I mean, he needs no introduction. He's the HOD and professor of pediatrics, and he looks after the rheumatology services and immunodeficiency services at the very prestigious PGI at Chandigarh. Next, we have Dr. Suma Balan, yet another giant in the field of rheumatology. She's the professor and HOD of Department of Rheumatology and Clinical Immunology at the AIIMS Kochi. So welcome, madam. We look forward to hear from you. And last but not the least is my very dear friend, Dr. Shikha Agarwal. She also she works in her own clinic at the PrEP clinic, that's Pediatric Rheumatology Expert Practice Clinic in Mumbai. But also she's attached as a pediatric rheumatologist at PD Hinduja Hospital, where I also work. So, and of course, Dr. Shikha has done her rheumatology training under Dr. Surjit Singh at PGI Chandigarh. So with that preamble, I welcome all of you, and I will hand over mic to Dr. Ramesh Bajania for the opening dignitaries statements. And then we have a very important personal, but not present physically present here, but has sent a video, and that is Dr. Naveen Thakkar, who is the president of the Indian, not only in past president of Indian Academy of Pediatrics, but now the current president of the International Pediatric Association. I'll run that clip a little later. First, Dr. Ramesh Bajania, just opening remarks.
Good evening, all dignitaries. Good evening, Nitin Bhai, for being there since the creation of our Gujarat Pediatrician group in 2014. I welcome all the panelists, allied panelists, as Nitin Bhai said. As a guest of honor, I welcome current Vice President East Zone, Dr. Santanu Dev. He's a senior consultant in HOD Pediatrics at Nazareth Hospital, Shillong, Meghalaya. He is an academic editor of IAP STG 2022 and EB members 2018, 19, 2022, and very, very active Vice President. Sir, over to Santanu, sir, to you.
Thank you so much, sir. I would not like to stand between you and the panel discussion. And my regards to Dr. Nitin Shah and Dr. Surjit Singh, whom I have heard many times in Guwahati. Several visits. Whenever he visits Guwahati, I go down from Shillong to Guwahati to listen to him, especially on Kawasaki disease. And also my regards to Dr. Shikha and Dr. Suma Balan. And I hand over to you, sir, to start the proceedings.
Thank
Yes,
you.
I acknowledge the presence of great academician Dr. Baldev sir, Baldev Prajapati sir. I was lucky to be his junior in BJ Medical College during 84 to 88. And I acknowledge the presence of our second guest of honor, Dr. Jose sir, who is a very close friend, and he has been executive board members of Central IIP 6 times. He was a national coordinator of that program 2022, national coordinator United Airway program 2018, and very active and very good academician to the core. Dr. Jose sir, few words of.
Thank you, Dr. Ramesh Bajani, and thank you, Dr. Nitin Shah, and thank you, the IEP Gujarat team, doing a wonderful job last several years they are doing, and it is very much appreciated by the pediatrician all over India and outside India. And so the viewer for Gujarat Pediatrician CME's webinar series are very much appreciated by the IAPN. So we are in the, actually we are expecting more discussion, more important topic we are going to discuss. None other than our Surjit sir is there, Dr. Somabalam is there, Sikha Agarwal is there. So I think this program will be enlightening all of us regarding the arthritis. Different aspect will be covered by Dr. under leadership of Dr. Nitin Shah and Ramesh Bajani sir. I wish you all the best. Over to Dr. Ramesh Bajani for further proceedings.
Thank you.
Yes, thank you, Jose sir, so much. Now, Nitin, straight away
so Dr. Ramesh, shall I play the clip, or before that we just acknowledge that we have Dr. Jagdish Chinappa, we have Dr. Jayant Joshi, Jayant Upadhyay, and so many other dignitaries, Dr. Bela Verma, Baldev Bhai, teacher of teacher, I call him Dr. Baldev Bhai, master of clinical examination. So let me just share the.
Yes, please.
Yeah. Sorry. This one. Share. Sorry. 1 minute. Okay, I understood. Yeah. So here is the clip.
Hello, I'm Dr. Naveen Thakkar, President of International Pediatric Association. I'm sorry I could not join today for this webinar, but I wish all the best to my dear friends Dr. Nitin Shah and Dr. Ramesh Bajania, both the moderators and organizer of these series of webinars, which are very useful, very good topics, great faculty, and I wish I can join in the subsequent webinar. Thank you so much.
Thank you, sir.
Well, that was Dr. Naveen Thakkar, the International Pediatric Association, our own colleague. So, shall we start, Ramesh Bhai? Or?
Yes, sir. Yes,
Okay.
sir. Please.
So
yes, sir.
Go ahead.
Nitin Bhai has curated this session in a way that he has taken 9 cases, and they all are very useful and common presentations in day-to-day busy practice of a general pediatricians. And I have taken 2 cases which, as a general pediatricians, I
So you can start with the first case, Dr. Ramesh.
Yes, sir. Then the most complicated one will be taken by Dr. Nitin Bhai. Now, Dr. Shikha, 1 4-year-old male child comes with complaints of pain in legs since last few weeks. Otherwise, he is active and plays the whole day, and no weight loss or fever. Pain is more in evening, but he sleeps well. And as usual pediatricians, they gave him vitamin D 60K sachet weekly for last 5 weeks, but there is not much improvement. On examination, child is well built, joints are normal, there is no pallor, no bony tenderness, no hepatosplenomegaly or lymphadenopathy. And the primary investigations showed hemoglobin 11 gram %, WBC 6700, polymorphs 45%, lymphocyte 55%, platelet was 2.3 lakhs per cubic millimeter, ESR was 18, and vitamin D levels was 85. So your thoughts, Sikha, from this much details?
Okay, so before I go ahead, first I would like to thank the organizers, Nitin sir and Ramesh sir. And special thanks to Surjit Singh sir for being here, my mentor and my guide, and all the dignitaries who are there. So coming to the case, sir, is what I feel is a very important case. So for a pediatrician, because whenever a child presents with musculoskeletal manifestations in the OPD, here we see there is pain in the legs. So we need to decipher whether the child has any joint issues or not. So here what I realize is it's just a leg pain. There is no arthralgia also. So there is no joint issue. Joint examination is also normal. So no arthritis, no arthralgia also. Just a leg pain which the child is saying more in the evening. And it is, I think, almost 20 to 30% of OPD which a general pediatrician sees, and which we commonly in a layman terms label as a growing pain.
So Sikha, what is growing pain? Because that word is generally even used by laymen also from Google search. Yes. What is it?
So basically, if you go by the medical terminology, na sir, it's benign, idiopathic, paroxysmal, nocturnal limb pains. So if you see the whole big terminology, it gives you all the answer. It is benign.
So mother is worried that hope it is not pathological.
So as a pediatrician, we need to figure out certain things to see whether it is actually pathological, any leg pain. So if there is any specific localization. So if the child is localizing to a specific site, for example, he's localizing to a tubal tuberosity and every time the pain is there, then we understand that there is an overuse of the tendon there. It might be like a Osgood-Schlatter disease or something which is causing tendinitis or bursitis there. If that is not localized, then we are, as a pediatrician, at a safer place that it is a wake pain. So it will not be a local. Usually growing pains are intermittent. It's not like every night the child would. So if we see this case, it is intermittent over the last few weeks. It has not caused so much severity. Child is sleeping well at night. Everything is there. So it's a poorly localized intermittent pain, more in the evening, in a child who is otherwise well. He's playing well. He's not having any fever. He's not having any systemic manifestations. So
right. It's a clinical diagnosis.
Yes, sir. It's absolutely a clinical diagnosis. So it's when we do not see all these features which lead us to diagnose or think of something else as a differential diagnosis, it is that point when we label the child that it might be a pain which is related, though growing pain is a misnomer. It's not during the peak growth period, but it is a benign pain. That's what we can tell.
So how will you treat it?
Shika, as I understand, you will also keep the child on follow-up to see whether he's evolving into something more sinister. Or just passing on without any trouble.
Tell the parents about the red flags. So the things which are there, whether there is any systemic manifestation, specific localization, or examination with limb asymmetry, then that points us towards something else which might be pathological.
So how will you treat Sikha?
So any test, na sir, we usually see nowadays parents always do a test and so that is very common. Ideally, no test should be done in this patient, and this patient was already done. So we see that the CBC is normal, CRP is normal. Now the AI guides the parents to diagnose and treat themselves or do the test at least by the time they come. So they do this test, which is in a beneficial state for us only. Okay, yes, see, all the tests are also normal, so it's good for us to counsel them. Treatment part, sir. So one thing which I would like to tell you here, sometimes what happens, growing pain sometimes may be overdiagnosed. So we have to consider 2-3 things here. One is a joint hypermobility, which might be a benign joint hypermobility, but the pain in that benign hypermobility is more localized to the joints. It's arthralgia which might be there. So that is one thing which we should rule out. That is not causing pain in that child. One is that. Or like I said, localized things which are not causing pain in that child. Sometimes it can be like a restless leg syndrome in the evening where anemia, so Nitin sir must be knowing anemia, which causes a restless leg syndrome. So that should not be present because that needs treatment. So if there is anemia, if there is vitamin B12 deficiency, or if there is a benign hypermobility which is causing arthralgia in child, that will need specific treatment. Otherwise, if we feel these are not there and a child is having actually a benign pain, then you have to have a good rapport with the parents, reassure them They can give mild massage, and if it's very significant someday, they might give a dose of paracetamol if
Okay,
required.
so it is more at night time?
Yes, more in evening, late evening, and especially parents sometimes complain, जिस दिन बच्चा ज़्यादा खेला, बहुत ज़्यादा active
Yes.
रहा, so that evening the child will definitely have pain.
So,
It can also sometimes awaken the child at night from
so
sleep.
can they give ibuprofen daily at night for few days?
No. So that is
No.
not recommended.
Right.
Daily is never recommended.
Right. Okay.
So I think
Clear.
as Sika very rightly said, you need to also keep in mind simple thing like iron deficiency,
Right.
which can be the restless leg syndrome, vitamin D deficiency, which is so common in children who are not exposed to sun. So these are things which you will see first and then try to correct them before. But like this child was given vitamin D5 session. After that, his
Yes.
levels were just
The
85.
thing is, giving
So-
vitamin D too much is also a difficulty.
Correct, absolutely. So you should never actually give it without documenting the need for it. That I completely agree with you. But over prescription of calcium syrup for months together and all, I think should be completely avoided. Anything else anyone wants to add? The other panelists on this case?
No, actually, I mean, this is a very classic story of a growing pain, like Sika has elaborated.
Correct.
And one of the important things is that usually the pain in the night is usually like either while going to sleep or
Yeah.
soon after going to sleep.
Absolutely.
It's very unusual that they wake up in the middle, like 2 a.m., 3 a.m. with pain and growing pains.
In
So that is
In
a-
fact, if they get up at 2 or 3 a.m. after deep sleep, I'm worried that is it my patient or it is Sika's patient?
correct.
Either having leukemia or infiltrates or just a growing pain. All right,
Yes.
let's move to the case number 2. So, Dr. Suma Balan, this is for you. So, this is a 10-year-old girl, so a little older girl, right? So, pain in the right knee. Now, she can localize because she's an old girl enough. So, pain in right knee and low backache since the last 15 days. She has mouth ulcers for which someone has given her multivitamins, as usually happens in the pediatrician's office. She had a culture-proven typhoid fever, which was successfully treated with 10 days of antibiotic almost 3 weeks back. So this looks like a sequelae of a past typhoid in a recent past. There is no weight loss or fever now. There was some hair loss, which of course was ascribed that you can have hair loss in a patient who has got enteric fever or such chronic illness. There is some slight joint swelling in the right knee is what the mother is a little worried, and the pediatrician is worried as to what is happening. Is not inflamed, is non-tender, and rest of the system examination is normal. A repeat CBC was done, which showed normal with a CRP which was borderline 28 and ESR again borderline 38. So your thoughts on such a case where there is some localizing as Sika was mentioning before, and there is a significant history of recent infection.
This is again a common scenario, and it's a post-infectious reactive arthritis.
Mhm.
We are dealing with an acute to subacute presentation with a clear history of a significant infection just prior to, and so there are different contexts in which reactive arthritis can happen, and the commonest cause would be viral infections.
Mhm.
Have post streptococcal infections where we also have specific clinical contexts like acute rheumatic fever, and we have post streptococcal reactive arthritis. Then we have, following genitourinary or gastrointestinal infections where you can get this kind of reactive arthritis. And the thing here is there is quite often actually in reactive arthritis, they actually have arthritis for you to see. It's
Correct.
usually an oligoarthritis and of the lower limbs.
Correct.
That's usually what we see. The post-streptococcal, you can see upper limb and small joint and a very varied presentation. And here I would say that it's too less a time to call it JIA.
Yeah, absolutely.
And there is also no objective arthritis. It's more of a arthralgia that is there right now, more than an arthritis. Maybe when I examine the patient, I might find an enthesitis maybe. That might be what is the tenderness in front of the knee and the slight swelling that the mother is talking about. It could actually be patellar enthesitis that we are seeing, which can also be part of a reactive arthritis syndrome. And investigations wise,
So
I think
with such a short history, would you investigate further? Or just wait and watch and give some anti-inflammatory or something?
absolutely, that's all that's required right now. You don't need to do anything else. there are no red flag signs here. There is no real evidence for a JIA here. I would give anti-inflammatory agents. My preferred
So what's your choice?
naproxen.
Your choice is what? Ibuprofen, naproxen, what is your choice?
So plain ibuprofen is not actually very easily available except as tablets.
Correct.
The ibugesic is something I don't like because it doesn't have enough of either paracetamol or ibuprofen in it. And, you have to give a very large volume if you want a proper anti-inflammatory response. Naproxen is easy. It's cheap and easy to dose. You can give it 2 times or 3 times a day. And
how long will you give? Till the time symptoms or?
Kind of a presentation, maybe a week and review and see. But depends. I mean, sometimes you have the classic post-genitourinary infection, post-gastrointestinal infection, the reactive arthritis where they come with very large lower limb arthritis, high inflammatory markers, and they need a treatment for a much prolonged time. Those patients can even develop chronic arthritis. So that is a different scenario. Here, I would give it for a week, maybe 2 weeks, depending on what the patient needs.
So in those
Very
cases
rare.
where it gets prolonged, does it lead to joint damage like in a typical GI patient, or it never leads to a long joint problem?
I think if it is prolonged, like if there is actually inflammatory arthritis that is chronic, then there is a potential for joint damage. And in that case, the treatment would be different. The follow-up would be different. The way we manage would be different.
Correct. And what, so what if it persists for few months? You already said that you look into, evolving into.
Yes, if it persists for a few months, I would actually evaluate this child and see whether what I thought was reactive arthritis has evolved to one of the JIA syndromes, very particularly a HLA-B27 related reactive arthritis, which if this child is HLA-B27 positive, this child can actually have a chronic reactive arthritis. Though actually, there are many clinical syndromes here. You have the Ritter syndrome, which is where they have, eye inflammation.
Uveitis,
they have the desquamation of the skin of the soles, and they have the arthritis part. And if those patients are HLA-B27 positive, they definitely develop a chronic form of arthritis. This could also be the beginning of a JIA. That's why it's important to follow up, to examine, and to evaluate subsequently, and see if the enthesitis and the arthritis are persisting. Yes, it could be an ERA JIA. So
let me ask you the question other way. How many of cases which are GIA, ERA, or spondyloarthritis actually are precipitated by an infection like this? Is it common or it's not that common?
It's very difficult to tease that out. I think you'll see some of the ERA JIA where they can come to you like a reactive arthritis initially. But generally the oligoarthritis and poly JIA, they're not really, you don't usually get a very clear infection picture. There is a history for parvovirus precipitating polyarticular JIA.
So just for the viewers, ERA means enthesitis-related arthritis, and spondyloarthritis would be what you see as a ankylosing spondylitis in adults, or something similar what you see in children. All right, let's move to the third case, and Dr. Ramesh Bhai, you can take it with Dr. Yes, Sikha, sorry.
So since we are discussing a reactive arthritis, so now we are seeing some post-streptococcal. So we always used to see, but we are also seeing some patients with rheumatic now as a reaction, because I think January, February, the pediatricians saw a lot of streptococcal sore throat. It discussed also a lot streptococcal sore throat. And so that if not treated, one of few patients we have started seeing who have actually carditis also.
Actually, we had a lot of scarlet fever coming with angina like picture, some of them progressing to a complete picture, but they usually didn't have joint pains after the fever went away. So it was more like during fever of pain, which you can see in any viral infection. Let's move to the case number 3. Dr. Ramesh Bhai, you can take it with Dr. Surjit Singh.
Yes, Surjit sir. Here comes a 9-year-old boy with the complaint of joint pains, which is off and on since 2 years of age. So when he was 7 years old, it's all started. There is no joint swelling.
2 years of age.
since 2 years of age. Yes, so
Ah,
since
so
last 7 years, he's having these
yes,
problems. So there is
correct.
no joint swelling. The pain is more after playing, and he gets tired at the end of the day. But he's a yoga champ and can do poses effortlessly and insert his hands below his feet without even bending knees. He had shoulder dislocation once in past while throwing a ball while playing a cricket. So, what is the likely diagnosis, Surjit sir? Because it's a long problem, 7 years.
Yeah, so the fact that it has persisted for so long means that it's likely to be a benign problem. There are no sequelae, and he's very flexible, and he's prone to some kind of musculoskeletal injury.
Yes, sir.
So all these are pointers towards a benign condition called joint hypermobility. It's important for a pediatrician to identify this condition so that we can save these children from getting unnecessary drugs and from getting unnecessary investigations.
So, sir, what further clinical clues one can look for?
It's largely a clinical diagnosis. So there are several other clinical tests that one can do. For instance, you can make these children touch their thumbs to the volar aspect of the forearm. You can ask them to extend the metacarpophalangeal joints, and they can virtually, touch the dorsum. You can extend their elbows and knees to beyond 90 degrees. And these children can touch their palms to the floor, keeping the knees straight, which a normal child cannot.
Yes, sir.
So these are the usual clinical clues which we use to pick up this condition.
So, sir, what common syndromes are related to hypermobility? Other syndromes?
So this condition can be syndromic as well as non-syndromic. So the common syndromes that can result in hypermobility are Marfan syndrome, homocystinuria, Ehlers-Danlos syndrome, even Down syndrome, and osteogenesis imperfecta. So whenever you see a child who is hypermobile, we have to be lookout on the physical signs of these syndromes.
Okay. So any tests required, sir, to diagnose?
Well, depending on which syndrome you're thinking of, you
Yes.
can do the test for that syndrome. Otherwise, this is a clinical diagnosis, and joint hypermobility is more common in girls, and it generally decreases with age. So the degree of hypermobility decreases with age. It is said to be more common in Asian and African children as compared to Caucasian children for reasons that are not very clear.
And any treatment, sir, one can offer?
Occasional paracetamol if required, but otherwise what is required is counseling of the parents and appropriate orthosis sometimes if they're prone to injury of some joints. Otherwise, if the parents understand what the whole condition is all about, and older children, if the child understands what is all about, they need to take common sense precautions. And most of the children ultimately do well without much problems, but you have
So
to
you can
protect
tell
them
them that
from
the ultimate prognosis is good, not to worry.
reasonable. Yeah.
I think it is sad, Dr. Sujit Singh, that we see some of these children doing all sorts of tricks in the circus or in some shows. They can bend their knees, and I mean it's pathetic because over the long time, if they abuse their joints, they can actually land into a chronic trouble. Correct?
Yeah.
Yes, sir.
Yeah. All right.
Any other faculties want to add?
Dr. Suma,
Sir,
Shikha.
Shikha, you can't hear you.
Thing.
Shikha, we can't hear you.
Yeah, sorry, sir. Sorry, I was muted. So these patients usually tend to have a lot of flat feet. So a lot of time they just come with ankle pain to us.
Correct.
So that flat feet may need that insole, and like sir already mentioned, that orthosis is required to help them.
We won't name, but there are some
Mumbai, if you know, now gymnastic classes is like all 4-year-old go to gymnastic classes. So that is when the child is hypermobile, the parents tend to put them more into gymnastic classes and more chances of joint dislocation.
Interesting. Yes, sir.
We won't name, but we know some famous film actresses also having some hypermobility and doing some tricks on some of the shows on the TV. Dr. Suma, you want to add something, or we move to the next case?
The only thing was what I tell these children is before they undertake activities, if they can do the kind of warm up that you're trying to do in sport, it does
Right.
help to reduce the pain after the activity.
Correct.
Yes.
Well,
So,
before
Nitin
we
bhai, you can take
move to
further.
the next case, actually we forgot that we have Dr. Trambak Datta from Zydus. So Trambak, you can just say a few words about, because Zydus is the one who has always provided us with this platform to discuss our cases. Trambak, over to
Yes.
you.
Yeah. Good evening, everyone. I'm Dr. Chambak, medical advisor for vaccines at Zydus, and I'll just take you 2 minutes to introduce all of you to Zydus.
Trambak, you can't hear you well.
Can you hear me now?
Yeah, better. Yeah.
Yeah.
Maybe you can do without the slides, because my slide is already shared. Yeah, sure.
I'll just do it without the
Yeah, yeah.
slides.
Okay, fine.
So just to introduce all of you to Zydus, it's a well-integrated pharma player with proven track record with over 23,000 people impacting lives across 4 continents. And our pipeline is rich with NBEs, the NCEs. We have Lipaglyn exemptia, that is adalimumab, and we're right now talking about pediatric rheumatology. In terms of vaccines, we have India's first indigenously made influenza vaccine, which is quadrivalent. And though now all the vaccines are specifically influenza vaccine is getting into trivalent mode. Then we also have Twinrab, Bilepsa, Zycov-B, and Oxemia, which is the oral analog for CKD.
I'm in a seminar.
And we have the tie-up with Etna Biotech in Italy and Vaccine Technology Center in India, in Ahmedabad. And our initiatives, the VCare initiative, to improve immunization rate in India. And all our brands, specifically Vaccine 4, now I wanted to update all of you that it comes now with a 25G thermometer, which is a universal solution to catering of all age groups. So with that, thank you all, and please continue. Thank you.
Thank you.
So
Sorry,
much.
Trambak, we forgot to give you
problem.
a platform to you in the. Okay, so we move to the 4th case, and again we come back to Dr. Sikha. So Sikha, this is a 4-year-old boy who's got pain and swelling and inability to bear weight on the left knee joint. So a very acute history of 4 days where he has got pain, swelling, and just cannot bear weight on that left knee. There was a trivial fall 3 days back. That's what the mother said. And after that, the child started limping, and now he's almost not able to walk on that limb. There is moderate fever for last 5 days. So high fever and no history of TB contact. On examination, the child is well grown. His left knee is warm, tender, swollen, and erythematous. And while touch, it's also very warm. The other joints and system examination are normal, so a single joint involved. A child was treated with oral cefixime and ibuprofen by the general practitioners, but of no relief. And this is a CBC which was done before he came. His hemoglobin was 8.5. What was driving that low hemoglobin was a microcytic hypochromic anemia. As you can see, the MCE was 65. WBC count is very high. It has got polymorph of 85% and lymphocytes of 15%, a normal platelet count, a CRP which is very high, 150. ESR is okay, 28, little high. And the X-ray knee was done before he came, it was normal. So what are the causes of such acute monoarthritis and what further investigations? So this is the clinical background you have, Sikha, to answer the next 2 questions.
Okay. So thank you, sir. So in this, we see there is acute. So there is a fever. There is acute arthritis, which is involving a single joint, the left knee joint.
Correct.
3 very important differential diagnoses for any acute monoarthritis. One is trauma, but here we see that trauma is very trivial. So usually parents will give a history of trauma with anything because bacha hai, girte rehta hai. We have to identify whether it is significant or not.
Absolutely.
So one is. Second is hemarthrosis. So here he's a 4-year-old boy. If you do not give me the investigation findings, so 4-year-old boy, so of course hemarthrosis will come to my mind. So we'll always take a family history, and other history is there or not to see whether there is bleeding into the joint or not. And third, important thing is infection. So
Correct.
infection is a septic arthritis, which seems likely because the child has have a high grade fever here, moderate to high grade fever. That's what you're mentioning, and the C-reactive protein is very high. TLC is very high.
Yes.
First line investigations which have been done. So it seems it is an infective monoarthritis.
And he has a
which-
polymorphonuclear
so TLC
high
high with,
levels. Yes.
and then anemia, which must have been predisposed already, iron deficiency anemia, which is pushing further with the sepsis here,
Correct.
and C-reactive protein is very high.
Correct.
Further investigations, the imaging is very important in this children, sir. So X-ray usually will not give us in a septic arthritis any picture within first 2 weeks. Sonography, in a limited setting, of course, we can do sonography, but in a affordable setting or in a setting where everything is available, MRI is one of the first important choices because one of the rheumatological emergencies is a septic arthritis.
Correct. So the MRI will show you beside joint, maybe some osteomyelitis or some
yes. So
erosions.
usually in kids, what happens since the metaphysis is intracapsular, so there is usually either an osteomyelitis which is leading to a secondary septic arthritis or septic arthritis which spills over to cause osteomyelitis.
Perfect.
So that's very common in this, and there is a hematogenous spread which happens in pediatric age group.
Correct.
Another question about aspiration. So yes, very important. And sometimes if there is a frank pus, then there is a debridement which has to be done to relieve that pus.
Correct.
So actually we used to do a lot of debridements, but now first aspiration culture and see how the fluid is and see how the response, and if required accordingly, we think of doing a debridement or calling on the orthopedic surgeon for this.
So the eternal issue, whether it's bacterial or TB, of course, this child is such high count, yes, but maybe a little longer duration, counts not that high,
Yes.
pre-treated with some correct antibiotic comes to you, then you always worry, is TB or not TB? How do you go about?
So, like you already mentioned, chronic history, not very acute history. Then there is a history of contact if you see in the family,
Right.
which is tuberculosis is there, or child has had a pulmonary tuberculosis or something like that. Then the chances is very high.
Correct.
And in tuberculosis, usually we prefer for synovial biopsy to go ahead to see, and of course all other tubercular workup, which you have taken a very good 2 sessions previously already on tuberculosis. So
Yes.
we need to work up the child for tuberculosis, rule out
Correct.
tuberculosis, because again it is a joint eating disease. So
Correct.
if there is osteoarticular tuberculosis, we again have to act fast only because it will eat up the joint, cause more
Correct.
erosions and
Correct.
affect the child.
So the one thing is that when aspiration done, don't forget to send it for TB culture and for gene expert, because you may be lucky, it can come positive. Nowadays, a lot of fluids, gene expert also, though the sensitivity is low as compared
Very
to
low.
sputum, but
It
still
is
is worth doing it.
so
So especially with a little chronic history, yes.
yeah.
All right. Now, how will you treat this child? This child is given cefixime. You have any idea? Any?
So we have to understand what is the commonest organism which will cause
Absolutely.
septic or osteomyelitis. And Staphylococcus is the organism which is the commonest one which will cause. So we have to understand that a staph cover is very important in this
Correct.
child. Also, clindamycin we add usually when there is this one, because the bone penetration is very good, and for the toxins it's very good to add clindamycin.
Correct.
IV was so initially we always start with IV antibiotics.
How
Initially,
long will you give IV? Now, suppose you did a tap and it showed frank pus. Now you give for what? 2 weeks, 3 weeks, and then switch to, and total duration of antibiotics how long?
So again depends whether the child has only septic arthritis, whether the child has only osteomyelitis, or whether the child has both. Usually when we see the child has both osteomyelitis associated with the septic arthritis. Initially we used to give IV antibiotics for a longer duration, but now it is guided by the clinical condition of the child.
Correct.
So if it's an
Perfect.
uncomplicated thing, there is pus has been drained, or there is no frank pus which is coming out and the fluid has been drained. So we usually give it upon depending on the clinical condition of the child. So which
Perfect.
can approximately 7 to 8 days or 4 to 7 to 8 days, depending on the clinical.
And
But
total duration?
to be higher. So for if there is a septic arthritis, then the total duration has to be 5 to 6 weeks.
Correct. Correct.
Sensitive antibiotic the child has.
Correct.
And MRSA is increasing. So we have to realize that MRSA is increasing.
Correct. How common is Lyme's disease? I mean, most of the Western book, when you read, they talk about Lyme disease as one of the differentials in joint issues. Brucella is another one. Chikungunya is the third one. We are talking infection coming with mono or multi-arthritic. I mean, have you ever seen a case of Lyme disease in our country?
So first I'll take chikungunya because I've seen that. So post chikungunya, we see arthritis, which is common, and it sometimes lasts for a longer duration. That is true. Brucella also we see, but it is not that much of an arthritis. It's more of arthralgia. You have hepatosplenomegaly, fever, lymphadenopathy, and then you
It's a
suspect it might be
PUO more than the joint
PUO
issues.
going on. So we see Lyme's, frankly, I haven't seen, and I'm very sure Surjit Singh sir might be giving.
Dr.
Might be able
Sujit
to
Singh,
give
have you seen a case of
of
Lyme
this.
disease at PGI or anywhere?
I'm not really sure, we have suspected Lyme, but have been
Uh-huh.
unable to prove it because the tests for Lyme are difficult to set up. So we have only recently set up our tests. So
Oh,
you
I
have
see.
to have a screening test and then a confirmatory test.
Oh, I see.
But,
Okay.
but I don't think I have seen a convincing Lyme disease so far. Maybe Suma has seen a few patients.
Yes, Dr.
I
Suma?
have seen in the UK. I've
Ah,
seen,
okay.
but I believe I'm told by friends in Calicut that they think they see some Lyme disease once in a while.
Okay.
I don't.
Now, why I put Lyme disease here is because of also my passion about vaccination. And there used to be a vaccine against Lyme disease from GSK, of course, which was withdrawn within a year because it was leading to side effect. But it's possible to prevent a Lyme disease. Anyway, let's move to the next case. So we discussed very well the an acute septic arthritis. So far we haven't touched to the actual JIA. We are only looking still at the other causes of an angry joint. So now let's move with Dr. Suma Balan to the next case. You have a 8-year-old female child. She has leg pain near both the ankles and she had some pustules in the sole since last 3 weeks. There was mild fever which was never documented. She gets tired by the end of the day and there is no weight loss or night awakening or swelling of any joints per se. So just the leg pains and some pustules and mild fever. Now, in past also she had pain in the knees and that time there was swelling near the lower end of the femur on both sides. There was some pustule in the palm, so people thought that maybe she has some infection which has led to the joint issue. So without really giving diagnosis, they just put the child on antibiotics like amoxicillin, ibuprofen and seem to improve over 3 to 4 weeks. Now, this time when she has come with this ankle swelling and pain, she has tender swelling near lower end of the right fibula, which is not actually in the joint, but it's in the bone. And X-ray was done, which shows osteomyelitis of the lower end of the right fibula. A CBC, CRP, and ESR were done this time, and they were normal. So an ortho opinion was taken, and he said we must do a needle aspiration, whether it's an osteomyelitis which is bacterial in origin. Some 3 ml of serosanguinous fluid was aspirated. It never looked like pus actually, but the child was treated with antibiotic and a smear, gene expert, culture, everything was done, which was negative. IV amoxicillin for 2 weeks, but there was no response. So that was something unusual. Now there is pain and swelling also in the right elbow region. So it's progressing from one joint to the other and while on antibiotic, and X-ray elbow again shows a feature of osteomyelitis. So the primary pediatrician is puzzled that is he dealing with a tuberculosis, and he started the patient on first line anti-tuberculosis treatment with 4 drugs, but there is no response after 2 weeks, and now he's worried, so he wants to refer the patient. So just to recapitulate, we have a 8-year-old girl. Twice she had, and first time knee pain and some pustule in the palms. This time leg, ankle pain and pustule in the sole. With a normal CBC, ASRS, CRP, given antibiotic, umpteen number of time not responding. Whatever the so-called cultures were all negative, and 2 X-rays, one of the ankle and now of the elbow showing osteomyelitis. So what is this, Dr. Sumabalan? Is it some atypical infection? Is it some MDR TB? What is are we talking about?
Okay. I think let's dissect the symptoms of this child.
All right, I'll go back. Okay.
Yeah. I think, see, the first thing is the pains that these are non-articular pains, actually, that this child is describing. I'm very, very sure that if we take a history, there will be awakening at night with the story. Because generally, when you have lesions within the bone, it causes bone pain, which causes children to wake up in the night. There are many causes for bone pain. One of them is obviously the most worrying thing that we need to worry about is malignancies like leukemia, even like osteoid osteomyelitis. All these can cause bone pain, actually. And we are seeing a child who doesn't have much evidence for sepsis or infection, but having a story for bone pain. Okay. And over time, what you're seeing is you're seeing this bone pain with evidence for osteomyelitis in multiple sites. It's becoming chronic, it's becoming recurrent, it's becoming multifocal, and there is osteomyelitis. So this is called CRMO, or chronic recurrent multifocal osteomyelitis. When you have only one site involved, it's called CNO, or chronic non-bacterial osteomyelitis. When you have multiple sites involved, we call it CRMO. And so
Dr. Suma, what is it? Is like, it's an inflammatory, is autoimmune, is it infective, or what is, or it is just a innate response?
it is innate response, it is auto-inflammatory.
Correct.
And there is a possibility that there can be an infection, some kind of a low virulence infection that might be the trigger for this innate immune response and this auto-inflammatory cadence that happens to these patients. Now, the other thing is, in this child is an older child, especially when it presents in very young children, who also have, other cytopenias, recurrent fevers, not thriving very well. There are some syndromic causes, syndromic causes like Majid syndrome, something called DIRA, etc., which can also present like CRMOs. That's just one, only about, less than 10% of CRMO. In fact, about 5 to 7% maximum would be syndromic. The rest
there's something like SAPHO in adults that you see, which is related to similar illnesses.
So I think let us say that CRMO is much more common in children. Adults, there is something called SAPHO, where they have SAPHO. So they have a constellation of symptoms. So there is synovitis, there is osteitis, there is pustulosis, there is hyperostosis, and
osteomyelitis.
And osteomyelitis. So there are a number of things, and acne. The A stands for acne. So there are all these things that come together in these patients, and it is, again, that is also an auto-inflammatory condition. It can be on the psoriatic spectrum, actually. So you can have this, even the palmopustular lesions you get in these children can be one of the manifestations of psoriasis.
How
Actually.
common is it to see this CRMO, in pediatrics? Like how commonly you see? Maybe
I see a lot. We have more than 80 patients now with as in our follow-up. So I do tend to see a lot, but I sit in a tertiary hospital, so I cannot be that. I'm sure that
Dr. Surjit, what about PGI?
Is more common.
What about PGI? A lot of cases of this in children?
Maybe 2 to 3 new cases every year.
Every year. Okay, that's quite often. All right. Okay. All right. Go ahead, Dr. Sumavan. So any other close differentials? I mean, first time you always worried about an actual bacterial or a tubercular osteomyelitis?
Yes. So if you have only one lesion, what we recommend doing for these patients, especially in a story like this, where you're getting, you're getting a history of chronicity, you're getting a history of recurrence, you're getting a history of multifocality. So in this case, it's not that difficult to make a diagnosis. But when you're getting only one site involvement, and what we suggest in these patients, if you suspect CRMO, do a whole body MRI. We do it under we have a separate protocol. So they just do only one sequence, actually. And we look to see how many sites are involved.
So, sorry to interrupt you, but if suppose someone cannot afford a whole body MRI, is bone scan equally good?
I wouldn't recommend, sir.
Okay,
I wouldn't recommend, because in children, you can get a lot of false positives because of growth on a bone scan.
All right. Okay.
And there is also a lot of radiation involved.
Perfect. Okay.
Okay, so I personally wouldn't recommend in children to do a bone scan. In adults, to do bone scans more common.
Yes. Correct. So is it that if you do the whole body MRI, you can actually pick up some silent lesions which were otherwise not evident clinically?
Yes, that's one of the main reasons to do a whole body MRI. So the advantages of doing a whole body MRI, if you might think you have only one lesion, but you might end up doing many others. So then you can avoid a biopsy. Because if you have only one lesion, it's always recommended to do a biopsy and to make sure you've ruled out other options before you go down the anti-inflammatory pathway of therapy.
Correct.
If you see multiple lesions, particularly if you see lesions in the vertebral bones, you have to be very careful because these potentially can fracture, can cause destabilization, and these patients straight away you would go on for the second line therapy or the bisphosphonate therapy for these patients. So it's really important that so all patients should have a bone scan. I mean, sorry, a whole body
Whole
MRI.
body MRI, right?
Yeah.
So which
And-
means if I understood correct, if I have a child who has got osteomyelitis at one side and he's not fitting into a typical osteomyelitis we see in a bacterial or tuberculous, and he's otherwise not as bad, and then if I do actually whole body MRI, I might pick up one or two silent lesion. That will give you a little more confidence for me to come
Yes.
to the diagnosis of CRMO.
Absolutely. At the same time, sir, one major caveat, you can get multifocal infective osteomyelitis also.
Correct.
And that it's a clinical call, actually. Those patients are going to be sicker.
Sicker.
They're
Right,
not going to be
absolutely.
well. Your CRMO
Right.
patients are usually not sick. They are
Right.
well. And you might have to even think about inborn errors of immunity in patients with
Absolutely. I was coming to
multifocal
that.
bacterial and infective osteomyelitis. Yeah, and MSMD can be a reason for multifocal tuberculous osteomyelitis.
Absolutely.
So all these things have to go through your head when you see these patients. But if you've seen a few CRMO patients, it's not that difficult actually to pick out. There are pathognomonic sites like the clavicle, especially the medial end of the clavicle being involved.
Correct.
That's a pathognomonic site, but I think in our series, we only have about 20% who have clavicular involvement.
Which is the smallest child you had in your series of 80, and which is of course.
Well, we have our younger children are Majid syndrome actually.
Okay. No, not non-syndromic.
I have non-syndromic also. I had
5-year
child, 3-year-old.
3-year-old. Okay, fine.
CRMO, yes.
I mean, I remember.
Yeah.
I remember a child. I mean, not a child actually. It was an adolescent boy who was referred to me that he would have this multifocal osteomyelitis and he will ooze pus-like thing. It will always go a mycobacterium from there. He was put on AKT, he wouldn't respond. We got his gamma interferon IL-12 loop testing done, and he turned out to be MSMD. So maintenance susceptibility to mycobacterial disease is one thing which we should not miss in a patient who has got recurrent tuberculosis, especially presenting as a multifocal osteomyelitis.
So you said a very
basidiosis. Yeah.
You said a very important thing. You said it has pus. In CRM, you don't have pus.
Exactly.
Collections.
Exactly. That this child had open sinuses from all these bones, and every time they would swab it, it will show a mycobacteria.
So
all right, what is the treatment for CRMO, madam? I mean,
so treatment is anti-inflammatory. The first line is actually NSAIDs like naproxen. And then the second line is bisphosphonates. Then we use other medications like we can use in methotrexate, sulfasalazine also helps these patients. And anti-TNF for a selective group of patients.
Because it's an autoinflammatory disorder, maybe you will use an biological, especially if it's very recurrent, you will use it a little upfront in an affording patient, or?
I use I would use biologics upfront if the patient also has evidence of like a bad psoriatic arthritis, has inflammatory bowel disease. These are some conditions in which you can additionally see CRMO.
Correct.
So
what happens to these children at the end? I mean, you treat them and they are all okay, or they keep on recurring?
Very well.
Very well. Okay. No sequelae, sort of.
Well, if you treat them properly, no. Otherwise, if you don't treat them properly, you can have, cosmetic sequelae from, like not fully repaired clavicles, mandibular. We have a series, in our series, we have about 12 children with isolated mandibular CRMO.
Oh, I see.
That can look very ugly because they have one jaw is huge.
Correct.
And
right.
So those kind of patients, I use bisphosphonate upfront as for the spinal lesions. But they resolve very well. They are treated it's a very satisfying disease to treat.
Correct. All right. So you, as all the delegates, you can see we are on the 5th case finished out of 9, and we have still not touched an actual JIA. So I showed you a variety of children having limb pain, joint swelling, osteomyelitis, etc., which are not truly the JIA. But I think it's almost now 50 minutes since we have discussed, and we have 4 cases which are now going to be some variety of GIA. So let me take the next case. Okay, so this was the question. What if the child was 2-year-old? You already said you think of Majid syndrome and the Dira syndrome, as young children are more likely to be syndromic. All right. So Dr. Sujit Singh, now 6-year-old boy, he had pain while walking for 1 week, which parents felt that, okay, he's a naughty boy and maybe he's over exerted himself, and now started having daily fever, which was high grade for 2 weeks. He gets rash when he gets fever, erythematous rash, and he looks very sick when his fever is very high. The moment the fever is given paracetamol, he responds, the fever subsides completely to normal, and the rash disappears, and he looks relatively okay till the time he gets the next spike, maybe again the next day. There is no weight loss or any bleeding. On examination, he had mild hepatosplenomegaly, so that was the worry that with this PO, whether it is a malignancy. He had no lymphadenopathy and he had no joint abnormality, no arthralgia, no arthritis now, though he had some pain while walking before. Now, what worries the pediatrician is a low hemoglobin of 7.5 grams, a WBC count which is very high, 35,000, with polypredominance of 74 and a lymphocyte of 26, and again a very high platelet count of 5.6 lakhs. So the pediatrician was actually thinking that maybe this child will have pancytopenia and he would have cracked the case as a patient of leukemia, but to his surprise, he comes the other way. So they do further tests for malaria, dengue, the PS5 abnormal cells. They are all normal. His X-ray chest, ultrasound, abdomen are done as a part of PO workup normal. Blood culture was sent, which was sterile. The further investigation actually showed CRP was 48, not that high, and ESR was 120. So again, very high ESR. So a little relatively low CRP and a high ESR. Borderline SGOT, SGPT, which were around 85 and 75. What is this?
So this is the typical clinical presentation of systemic JIA, in which the child develops fever, there is rash, which may not always be very perceptible. There is organomegaly. Some children may have lymphadenopathy. There is polymorphonuclear leukocytosis, thrombocytosis, which is a marker of inflammation, a high CRP, a very high ESR. So these are all pointers towards a diagnosis of systemic juvenile idiopathic arthritis. But since this is a diagnosis of exclusion, so you have to rule out other common causes of fever. But to the experienced eye, this is rather typical systemic JIA.
So can you describe, Dr. Sujit, what is the typical of the rash in a GIA and the fever pattern in a SGIA?
So fever in SGIA is typically quotidian. You may get 2 peaks every day, but it touches normal. And when the fever becomes normal, the child looks much better.
Correct.
So this is again rather typical of GIA. The rash is usually macular, erythematous, transient. It is there for a few hours only. Typically appears with the fever and then settles down. Rash can be sometimes somewhat pruritic, but is almost never vesicular and never purpuric.
Correct.
So the rash is usually more prominent over the trunk or the proximal extremities. But this rash can be easily missed if the child is not very fair. So in wheatish children with a wheatish skin texture, the rash may not always be very clear, but you really have to sometimes hunt for the rash.
Okay.
So
and what further tests? Yeah, sorry, go ahead.
So these children typically are more sick when they have fever.
Correct.
And when the fever settles down, the child looks more cheerful. So
Correct.
this again is a useful clinical pointer to the diagnosis of SGIA.
Unlike what will happen in leukemia, where the child will be sick anyhow. Yeah, right.
Yeah. So normally the rheumatoid factor and ANA both are negative in these patients, because unlike other types of JIA, systemic JIA is an autoinflammatory disorder. It is
Correct.
now classified as an autoinflammatory disorder. It involves an innate immunity, and
Correct.
rheumatoid factor and ANA are usually negative. And if the diagnosis is very obvious, you may not even do these tests.
Correct.
But if you do these tests and if they turn out to be positive, number one is you should review a diagnosis.
Mm-hmm.
But there are some studies which suggest that on long-term follow-up of systemic JIA, some children may develop RF and DNA positivity, but it's very unusual to have these tests positive at the beginning of the disease.
Correct. So this child was started on ceftriaxone by the pediatrician. The fever continued. The counts have now fallen suddenly, and so also the ESR. Is it a good sign?
No, this is never a good sign, because if the counts have fallen, you would be very, very worried.
Mm-hmm.
And a falling ESR, a fall in the counts in a setting of systemic JIA, this is almost like a medical emergency,
Mm-hmm.
because these are all pointers to a condition which is called macrophage activation syndrome.
Okay. So
So
any
these are
screening
all,
tests you can do in such a child in this scenario before he becomes too sick?
yeah, so we would closely monitor the fever, we'll closely monitor the counts. What happens sometimes is, you said that the initial platelet count was 6 lakhs or something.
Yeah, correct.
So now from 6 lakhs, it may come down to 4 lakhs to 3.5 lakhs. That means the platelets are in the normal range.
Mm,
But since they have fallen down from a very high count,
correct.
we would be very, very suspicious.
Correct.
So we would do the serum ferritin, we would do the triglycerides, we would do the transaminases,
Correct.
we would do the PTI and PTTK.
Fibrinogen.
Fibrinogen. So these will all be, help us in diagnosing this condition, macrophage activation syndrome, which is one of the major emergencies, medical emergencies in pediatric rheumatology. If you
Mhm.
delay the diagnosis, if you delay the treatment, even by, a day or so, sometimes
Correct.
the child can deteriorate very fast.
So are the criteria to diagnose MS same as that of HLH we see in a non-rheumatological condition, or are they a little more liberal in an MS syndrome type setting?
Well, there are several sets of criteria to diagnose MAS. The condition is, from the pathogenesis point of view, similar to HLH.
Correct.
So there are the Angelo Revelli's criteria, several other criteria have also
Mhm.
been given. We
Mhm.
generally, at the bedside, you would not, go around applying the criteria.
Perfect.
But yeah, if there are pointers to this condition, you would do a marrow, because if you get hemophagocytosis on marrow, that is corroborative. But
Mhm.
more important is that you start treatment immediately.
Correct.
Uh,
Correct.
yeah,
So
without waiting even for the
absence of hemophagocytes on a bone marrow doesn't rule out an MS if you have the setting and this type of picture.
Yeah, absolutely.
So
Absolutely.
same thing we also say for HLH, that if you are suspecting HLH, your marrow is normal, it doesn't mean it's not an HLH. All right. So treatment of SJIA without MS and treatment of SJIA with MS. So first, without MS, steroids, DMARD like MTX, or straight some biologicals.
It's SJIA is a tricky condition. Yes, we would generally start steroids. If the child is not very sick, we would use prednisolone 1 to 2 milligram per kg in divided doses, and then taper according to the clinical response. DMARDs like methotrexate, many of us would start DMARDs like methotrexate if the arthritis is prominent.
Mm-hmm.
So we would combine it with steroids. But theoretically speaking, methotrexate does not have much benefit for the other manifestations of systemic JIA.
Absolutely.
If the symptoms persist while tapering steroids, as happens so very frequently, then we would take recourse to an IL-6 inhibitor like tocilizumab.
Okay.
So in India, we generally
Mm.
don't use IL-1 inhibitor anakinra. Most centers in India would use tocilizumab because anakinra is not easily
Not
available.
Correct. So one question that always comes between a hematologist and a rheumatologist is that we always insist that, okay, you have an SGI like picture, you are never sure, do a bone marrow always before steroids, because once in a while you may miss a leukemia. I mean, is that the fear real or is just a fear?
No, I think it is always prudent to do a marrow before you start steroids because systemic GIA has no marker. So you
Correct.
can sometimes be dealing with, a totally different medical disorder. So you
Correct.
feel more confident, you feel better if you're sure that, the marrow is normal before you use steroids.
So how long you will give steroids to the child?
Several weeks,
Mm-hmm.
and you would try and taper it weeks to months, gradually taper it. If the child tolerates that, you continue tapering and try and stop the steroids. But what is more often seen is that the moment you start tapering steroids, they would develop some recurrence of symptoms, and that is the time when you would consider using tocilizumab.
Biological. Okay. Is there a role of pulsing methylprednisolone in a very sick child, or you always start with oral steroids?
Yes, if the child is very sick, especially if the child has serositis, that is the time when we would start IV methylprednisolone. Occasionally, we have had children who have had macrophage activation syndrome as the presentation of systemic GIA. Now, that can be a very difficult clinical problem at the bedside, but one has to be prepared for it because there the threshold for diagnosis is very low and the time to react is very short.
And
So
the dose
MAS
of
can
methylprednisolone
can
for MAS will be very high to start with, or
10 to 30 milligram per kg.
and for 2-3 days, and then
For MAS will be 30 milligram per kg.
30 mg, correct. Okay.
Yeah, 30 mg per kg. If it is just systemic GIA, depending on the severity, maybe 10 to 30 mg per kg.
What happens to these children over long term? What happens? I mean, you said they may, when you taper, they may need biological. Suppose you give biological, they may go into prolonged remission. Ultimately, they all recover, or there is some chronic damage, or
Very variable. It's very variable. So we've had children on tocilizumab for more than 5 years. We've tried to taper off tocilizumab. Some children, again get a relapse. So it's very, very variable. Children who have an associated arthritis, they would need methotrexate. So again, it varies from child to child, and it can be very challenging managing a child with systemic GIA.
and any of the children can have other associated systemic, like say IBD or some other innate immune response diseases, or like
Generally,
role of
not
doing
just
calprotectin and thing like that.
we would generally not do it.
Not do. Okay.
Yeah.
So I think this is an important disease, as Dr. Sujit Singh mentioned, and you cannot afford to miss the diagnosis. Number one, to misdiagnose. Number two, and not to treat in time is number three. Especially if they are crashing with an MAS, you have very little time at your disposal. And we have seen children who are well today, and when you count around next day, they are on ventilator, and third day they are gone. That's because MS was missed. So pediatricians feel very happy when the counts fall. Now, when you treat a child and the counts fall, that's fine. That's the therapeutic response. But you haven't started a specific therapy and the counts fall, you are actually waiting for a disaster like MS to happen. And if you are not very alert, you can actually lose the child. So, very well learned points as far as the SGI is concerned. Let's move to the next case, Dr. Sikha. A 3-year-old child, a small female child, pain and limping while walking since 1 month. So that's a long history. There is no fall or trauma or fever or weight loss to suggest a primary reason why she's having this limping. In past, she had swelling of the left ankle. As usual, the general practitioner gave some ibuprofen and gave some relief. And there is swelling of right knee and the left wrist also when she has come now with you. So she has basically a knee and a wrist and the left ankle so far involved as what it looks like. The right knee and the left wrist show actually swelling and arthritis, though there's not much tenderness or there's not much warmth, or I mean not much redness. There is no lymphadenopathy, organomegaly, rash, weight loss, bleeding, night awakening, etc. to suggest a sinister disease like leukemia, because that always comes first in your mind when you're a young child coming with limping and things like that. Then the CBC is near normal. The ESR is just 25, CRP is negative. A Mantoux and an X-ray test was done as a part of the illness. It was normal. Someone had done uric acid and LDH as a screening for malignancy. That also normal. So what is the differential diagnosis? I mean, will you label this as oligoarticular GI based on this history of a month's pain and limping?
So I think, sir, here you mentioned that there is more than a month, because in the past he
Yeah.
had swelling
Right.
on.
Right.
So here we are, of course, dealing with something which is going for a couple of months, where it involved initially the ankle, there were some NSAIDs given, relieved, and now again, within a few weeks, maybe the child is having the knee and the wrist involvement also. So definitely a chronic process. And like we discussed in a and very different case from what we saw and we discussed with Surjit Singh, sir. So there is
Correct.
systemic manifestations like high-grade fever or other rash and things like that are not there in this child.
Correct.
So we are dealing with chronic arthritis. And one of the commonest reason to cause a chronic arthritis in pediatric age group is juvenile idiopathic arthritis.
Correct.
And we see here that there are 3 joints involved. Other investigations like a chronic infection, so tuberculosis has been ruled out. Even an acute case where they think of malignancy, things like that have been ruled out. So my first differential
And the
diagnosis.
CRP is negative, ESR is almost near normal, and a CBC is completely normal. So relatively non-sick child, 2 months history, 3 joints involved, enough to put into definition of oligo. What do you mean by oligo and poly? I mean, what is the cutoff for the
So
joints?
to go classification, so of course the classification system in 2023 by Printo has been changed, and they are not deciding depending on the number of joints involved. In fact, they do divide into 5 categories, whereas an early onset ANA positive disease, then RF positive disease, systemic JIA, enthesitis related, and the rest is in the others category.
Other group, perfect.
Initially, oligo was less than equal to 4 joints, and if it's more than 4 joints, then it becomes a polyarticular JI. So ultimately, we are diagnosing as a JI, and then the treatment would guide us accordingly to that.
How common is uveitis in this? I mean, will you worry about?
So articular GI, if we say the commonest variety of GI who have a uveitis, and they have an acute chronic anterior uveitis. So chronic uveitis, which is usually doesn't have any symptoms. So the child will not come with a red eye, except in an is related where the child would come with a red eye. So it's very important to see this child. And like Surjit Singh sir used to always say, the children ki ek baar don't come to a rheumatologist, but always go to an ophthalmologist.
Go to an ophthalmologist, correct. And how frequently they undertake this ophthalmic evaluation till the time they are active?
Certain investigations like ANA guide us to tell us how frequently. If it's an ANA positive disease, less than 7-year-old child or a very younger child, then it might be a 3-monthly follow-up requirement. If they do not have uveitis at first go. Correct. If they have according to the uveitis and symptoms, then they follow up accordingly.
And so you talked about these antibodies. So you said ANA, if it's positive, it's more likely that he may be prone to uveitis. What about the RF? Like polyarticular RF is positive, but in a small child also can you get RF positivity? And what about the other like dsDNA, the RO-LA, SM, RNP, ANA, etc.? Will you do it in a child like this or? Yeah.
Coming to RF first. So again, like we already said that all children, even if we do an RF and RF negative, it doesn't lead us to a not diagnosing GI. You have to remember that it gives a false sense of security to the parents also कि RF negative and बच्चे को arthritis नहीं है. So we should already decide, counsel them, and then if it's a polyarticular disease, it's more of a prognostic marker for us. If we are doing
ANA, you said already, it must be done.
We do it for all.
Right. What about others?
Bodies, like if the ANA is positive, whether we go ahead to do an ANA panel or an ANA blot kind of a test will be guided by only the systemic symptoms. So if the child, and if you're thinking of something else or different
in this child,
I would rather not do, because
not
the
do,
CRP, everything being normal, though CRP can be normal in a lupus also, but he doesn't have fever. The CBC is not showing any neutropenia, leukopenia or anemia or something like that. I would not do a blot in this child, even if they be positive.
Generally, they say the CRP and ESR are normal in oligoarticular. If they're high, then what does it tell you? Especially also have some anemia and things like that.
Not always CRP is normal. We see a lot of patients who have a high ESR, CRP in oligoarticular GI also, and who have anemia also because of anemia disease, which is superseded by the iron deficiency anemia, which we commonly see.
And
if we are seeing a child with, like we already discussed, very high fever, significant anemia, ESR, CRP high, so of course leukemia is one of the things which come to
Correct.
our mind, which should be ruled out.
And
The
again,
second-
they say oligoarticular normally don't have backache and hip joints and things like that. I mean, if they're positive, it tells you that probably the child is not oligo and is going to progress into something else.
So this child is usually 3 years. So if there
Yes.
is a joint involvement or a back pain or a sacroiliac joint involvement, then we think of enthesitis related arthritis as one of the possibilities. Or also we examine the nails of the children. So the nails of the children also tell us whether there is any pitting or any
Psoriasis.
psoriatic arthritis is there or
Right.
not. So that also helps us in identifying what disease we are dealing with.
Again, imaging in such children.
Yes, yes. Sonography, sir, is very like upcoming in the patients with JIA, and we can pick up an active synovitis. It might sometimes guide us whether there is how is the vascularity in the Doppler. So it can pick up active synovitis. Of course, now we inject also. We do a sono-guided injection if we are giving an intraarticular.
Perfect. Okay, so I was coming to that. Would you give NSAIDs in a relatively milder child, or would you start steroid that to oral or intraarticular?
So NSAIDs, of course, in the initial part, but I don't think so. Alone NSAIDs with 3 joint involvement can help us. That the child definitely need a DMARD to be there. Intraarticular steroids best for an oligoarticular JI, especially 1 or 2 involvement. Just inject the joint and it's very good. So
So which one you inject, triamcinolone or?
So triamcinolone hexacetonide is also available now in India, and acetonide was always there. So triamcinolone.
Okay. And how frequently you have to actually give sometimes?
So it's a one shot only, which we usually do if the child is asar aa gaya hai to. Otherwise, if it should not be more than 3 shots in a year.
Correct.
If the child is requiring more than that, that means that's not working properly.
Correct.
So we should give a step up of the therapy.
So systemic steroid in such case?
In this patient, I would rather not use
no,
it.
not in this case.
The patients, we use a bridge therapy. Only the systemic variety where sir discussed about the longer duration of systemic steroids that we have to use. Otherwise, in JI, a longer duration, it can be a bridge therapy till the time the methotrexate or whatever DMARD we start takes over.
And what is this extended oligoarticular JI? Is it just a artificial term or it actually means something?
So again, in the newer classification, they have given away with extended and persistent. But extended, if after 6 months we see that there are more than 4 joint involvement, then that's an extended, which behaves like a polyarticular GI. So the prognosis is more like a polyarticular.
And any role of biologicals in oligoarticular, or generally they are doing well on?
So usually oligoarticular do well on DMARDs, but rarely in certain cases we have to use if there is a joint which is not responding to the intraarticular steroid or the DMARD, then anti-TNF medications are very good in these patients also. But it is rare.
Which biological?
Anti-TNF medication, so it can be done or it can be adalimumab.
All right. Prognosis, long-term joint?
Usually good if it's picked up early and the joint deformity has not set in. If the child is put on a good physiotherapy along with the medications, then the long-term prognosis is good with these children.
Right. So younger child, a female child, few joints, not very sick looking, you ruled out other causes of joint involvement, and your markers are not really out of hand, and look for uveitis definitely, even if there are no symptoms, especially if ANA positive. We need not do a panel of tests because some of them are useless in such a given case. Most of them respond well to either intraarticular steroid and or DMARDs. Let's move to the last 2 cases. Dr. Suma Balan. This is a 12-year-old male child. Pain and swelling in both the knees and ankles since last 3 weeks. There is no fever or weight loss. There is bilateral knee and ankle swelling, though not much redness. And there is no lymphadenopathy or organomegaly. So it looks like a symmetrical disease involving both the knees and both the ankles. In the next 1 week in front of you, he has now pain and swelling in bilateral fingers and wrists, but there is no back pain. So now upper limbs also involved. The CB shows mild anemia, a normal WBC and normal platelet. ESR is high at 80, the CRP is normal. So now this type of presentation in an older child, multiple joints.
So there are 2 things here. One is we have a polyarticular presentation. It's a symmetrical polyarticular presentation with this involving large joints as well as small joints.
Correct.
So this is the kind of situation in which you think about polyarticular juvenile idiopathic arthritis. And at the age of 12, he can be rheumatoid factor positive as well. It's not only girls, even boys can be rheumatoid factor positive. And, under 10 years of age, you've asked, can it occur? Definitely. So there are two peaks of polyarticular disease. We have the young, toddler, 5-year, that age group. And then you have the older peri and adolescent group. Who also develop polyarticular JIA. The older group are likely to have the rheumatoid factor positivity.
Correct.
The younger group are highly unlikely to have rheumatoid factor positivity.
So when do you do RF, ANA, and the CCP, and do you also do the other panel like ROLA and RNP, SM, etc. in a patient who is presenting like this?
So the interesting thing is here, I would see what all is available to me from a clinical perspective. So this child, definitely I do a rheumatoid factor. If a rheumatoid factor is positive, that's perfectly, that fits in with the clinical
diagnosis
picture that we are seeing. Now, there could be other features in this child that make me think about connective tissue disease rather than just a rheumatoid factor positive JIA. So there could be dry eyes, there could be parotitis, there could be other features of what we call Sjogren's syndrome.
Correct.
And in that case, an ANA and doing the ENAs, the ROLA, etc., would be used. If that kind of a feature is there, okay? Anti-CCP has a very, very small role in pediatric JIA. Because most pediatric polyarticular JIA are actually rheumatoid. I mean, the ones who are rheumatoid factor positive are actually rheumatoid factor positive.
Correct.
You have this kind of patient who has a symmetrical, large and small joint. If he's rheumatoid factor negative, I might consider doing an anti-CCP. In my practice so far, in all these years, I might have requested an anti-CCP about 10 to 15 times. That's all.
Okay. So if RF and CCP is positive, does it mean that he's going to go into further complications like
it
spine involvement or hip joint involvement?
No, it suggests chronicity. It suggests that this is a child with JIA who's going to have the disease in adulthood too, and will need to have some kind of treatment going on, and will need to be transitioned to an adult rheumatologist when he's much older.
Correct.
So
now the management, initial management and the specific therapy.
I wouldn't treat him with, we have a chronic inflammatory polyarticular systemic disease. I would not manage him on NSAIDs alone.
Correct.
He needs upfront the first line methotrexate. And along with methotrexate, as Shika has explained previously, it takes a good 12 weeks sometimes to kick in. So if for that in-between period, I would use NSAIDs and bridge dose of steroids. Bridge dose of steroids means you use very small dose, 7.5 milligrams per day, and wean it down. And this has to get the symptoms and the inflammation under control before, because methotrexate is a DMARD, is a disease-modifying agent.
Correct.
Steroid and the NSAID are only symptom relievers. Correct. They are not disease-modifying. They do not prevent deformity. That's what we realize.
Correct. And what about biologicals?
Biologicals I would use if they were not responsive to the first line. In fact, it depends on the affordability of a patient. You can think of combination DMARDs if they cannot. The textbook recommendation, if they fail methotrexate or if it's inadequate response to methotrexate, you go on to biologics. However, if our patient is not affordable, I would go on to combination DMARDs first before I think. And now we also have small molecules, what we call JAK inhibitors available, which are a lot cheaper that we can use. So many options.
Yeah, I think in polyarticular, all the more reason to have very vigorous physiotherapy and occupational therapy so that the patient can be rehabilitated as normal in the society.
Yes.
And what happens to the children in long term as far as the joints are concerned?
So
similar to adults or?
So the rheumatoid factor is actually a big player here. Those who are rheumatoid factor positive are likely to have chronic disease and need to stay on DMARDs.
Correct.
Long term. Okay. The ones who are rheumatoid factor negative do have a chance of over time remitting and being able to even stop medications.
Stop the medications. Fine. All right. So we move to the last. Yeah. Sorry. Go ahead. Go ahead. Sorry.
Not all of them, but a good number.
Many of them. Okay. So that brings me to the last case with the maestro, Dr. Surjit Singh, a 12-year-old male, pain and swelling in the right ankle since last 4 weeks, which is more at night or early morning when he gets up and becomes better as the day passes. The pain is relieved with hot water bag or a hot shower, but generally not relieved with rest. That is what the parents say. In past, he had pain in his right foot and near the calcaneum, which are ascribed to the football related strains and sprains that he was a keen football player. Now he has developed swelling in his right hand middle finger. So that is worrisome to the parents. It's not just the normal strain and sprain. And there is past hip joint pain that was often not relieved with rest. He has now arthritis of the right ankle, middle finger, and swelling of the tendo-Achilles region. His CBC, ASR, and CRP are normal. So what is this type of clinical presentation in an older boy looks like?
So when you have an older boy presenting with asymmetric lower limb arthritis, so this is quite typical. The involvement is usually in the lower limbs and it's usually asymmetric. So this is what is called as enthesitis related arthritis or HLA-B27 related arthritis. So the age group is specific. It is more common in boys, and this is the typical presentation.
So what's the difference between arthritis and an enthesitis?
Enthesitis refers to the site where tendons or ligaments get attached to the bone. And involvement of this region is typical of this subgroup of juvenile idiopathic arthritis.
Is it part of the spondyloarthritis in children, and what all things come under this one term?
Spondyloarthritis is a broad terminology, so which includes many different conditions such as psoriatic arthritis, ankylosing spondylitis, arthritis associated with inflammatory bowel disease, reactive arthritis. So that is an umbrella term.
Correct. Is uveitis common in this type of patients, or it's not that common?
Uveitis is not common in ERA, but very dramatic. So it occurs in maybe less than 5% of patients with ERA. But unlike the uveitis of oligoarticular GIA, which is almost always asymptomatic, this uveitis it presents as an angry red eye. You can't miss it. The patient cannot miss it. So it's an acute anterior uveitis, which is typical of ERA.
So it's rare, but it is very dramatic and always symptomatic.
Yeah.
Okay. So what if the spine is also involved, like the child also has backaches, pain in the sacral region? Would it mean that he's now going to head towards like an adult type of ankylosing spondylitis like picture?
The spine in ERA in children is usually not involved in the first few years. And it's only after the first decade that the spine starts getting involved. So, and both are basically forms of juvenile spondyloarthropathy. If it is ERA, it is undifferentiated spondyloarthropathy. If it is juvenile ankylosing spondylitis, we call it differentiated spondyloarthropathy.
So would you always do an HLA-B27 in all patients of ERA or only when they have the spine involvement?
We generally do in all patients of ERA.
Okay, all right. And are there any other extra articular manifestation in this patient, like association with other inflammatory disorders?
Yes. So you already mentioned uveitis, which is, you have to be on the lookout with this condition. Many children have associated inflammatory bowel disease. Some children can have valvular defects like aortic insufficiency, mitral insufficiency.
All right. And what imaging will be required at the onset and on follow-up in patient with ER?
It depends on the clinical picture. But if it is an older child, say 10, 12 years old, you would perhaps end up doing an MRI of the sacroiliac joint.
Correct.
And follow up, you would do MRI of the lumbosacral spines, again, depending on the clinical follow-up.
Symptoms. Perfect.
Yeah.
How will you manage this child? NSAIDs, biologicals?
Generally, NSAIDs, methotrexate is good for effective for the peripheral arthritis, but not for the spondyloarthropathy.
Correct.
And if spondyloarthropathy is very prominent, then you have no choice but to go on to biologicals like adalimumab.
So as early as possible?
Depends on the the clinical course. I won't say as early as possible, but yes, some children who do have reasonable spondyloarthropathy, you would end up starting adalimumab.
All right. So I think we have discussed all the 9 cases, some general issues before we wind up. So Dr. Suma Balan, first, when I was talking to you, you said about the shared care. These children can be prone to infection, fevers while they are on biological and or methotrexate. How do they take care of it? So what is the role of pediatrician in this management?
So I think, we have to actually give strength to the parents by, both of us working together. The pediatric rheumatologist is usually in a tertiary setup, and the pediatrician is available close to home. And when the child has intercurrent infections, needs vaccinations, etc., it's much easier for the child to go to the local pediatrician. If there are any doubts, it's not necessary that the DMARDs need to be stopped with every URI. But if a child is having a very, significantly febrile illness, looking sick, pneumonia, needs admission, etc., possibly I think the pediatrician could just ring the rheumatologist and explain and do what's necessary. Regarding
one question I want to ask you: are the vaccines, especially live vaccines, safe when someone is on biologicals?
So we actually have protocols for these things. So most the kill vaccines are safe at stages. We would not be giving the new, like we would not be giving the first dose of MMR for somebody on a biological.
Correct. So how long you wait after you stop biologicals? 4 weeks, 6 weeks before you start live vaccines?
Yeah. You can possibly just wait for 2 half-lives of that biological, and then you can.
Okay. All right. Okay.
Okay.
Now some
a bigger problem.
Yeah, some quick management issues before we wind up. General goals of treatment, Dr. Suma, in any patient of JIA.
Early diagnosis, early appropriately aggressive treatment, and multidisciplinary care.
Correct.
This can make a lot of difference in the long time.
So as to make him more fit and involved into day-to-day activity rather than get secluded in the society.
No rest business. There is no question of rest. We want them to be active. We want them to be doing things. We want them to be mobilized.
Perfect. Shikha, intraarticular steroid, choice, dose, and frequency. You said it, but just to reiterate, that's the commonest thing a pediatrician will see when you practice.
Yeah, so intraarticular steroids, triamcinolone, acetonide, hexacetonide, those we suggested 3 per year, not more than that, basically. And frequency is that only. So dose it depends on the joint. So which joint are you actually the knee? So it's if you're using the acetonide, then it's 1 mkd. So it depends on the joint which we are using.
Okay, Dr. Sujit Singh, if you have to use oral steroid, choice, prednisolone, deflazacort, dose, duration, and monitoring.
We only use prednisolone. The dose is 1 to 2 milligram per kg and tapered according to the clinical response. Duration is, again, depends on the clinical response. May go on for several weeks, occasionally for several months. And monitoring is the usual monitoring that we do with steroids.
So blood pressure, sugars, look for cataracts, infections, supplements, calcium, vitamin D. Perfect. Dr. Suma, NSAID choice, duration, and monitoring.
So the NSAIDs that are suitable in childhood for long-term use are ibuprofen, naproxen, tolmetin, and in the older children, toricoxin. Now, the doses are we have to remember that the anti-inflammatory dose is much higher than the antipyretic dose.
Correct.
So using ibuprofen, You use up to 20 milligram per kilo per day for antipyretic effect, but for
Okay.
inflammatory, it starts at double that dose.
Okay.
Naproxen is again 15 to 20 milligram per kilo per day in 2 to 3 divided doses. And etoricoxib is only in the older children where we use
Right.
higher. Indomethacin is also used in systemic JIA and also in the.
How long can you use this without worry about nephrotoxicity? Like few weeks?
Yeah, few weeks, months. You do monitor in between, but I have never seen nephrotoxicity in the appropriately used doses.
Okay.
In children. In
All right.
CRO also we use quite long duration NSAIDs.
All right. Dr. Shikha, methotrexate is something which many patients of GI are on. So dose you use, duration, how long? And you give folic acid, unlike in malignancy where we don't give them. But here you would rescue them with folic acid or folinic acid, and why?
So dose 10 to 15 milligram per meter square per week. That is important. Preferably a subcutaneous dose than an oral. But of course, the child in a periphery, we should be sure that they'll take a subcutaneous dose and nothing, no other. Duration at least 2 years into disease remission. So it's very wrong to taper and stop it very early. Folic acid, yes, we give. It is a dihydrofolate reductase inhibitor, and so not on the day, but maybe 2 days a week where we give the folic acid supplementation to these children. Monitoring, basically bone marrow suppression. So CBC has to be monitored, excretion through the kidneys, creat has to be monitored, also through the biliary tract. So SGBTs have to be monitored.
Perfect.
Initial monitoring 6 weeks ke andar, and then maybe 3 monthly. All
right. And the last question of the day, Dr. Surjit Singh, biologicals, a lot of confusion, but now with biosimilar available, which are much effective, they are a little more liberally used than ever in the past. So how easy it is to get these biological similar? What are the costs in general? First 2 questions, then we'll come to Anakindra.
Well, a large number of biologicals have become available and they are being used very, very liberally. And that is, in many cases, a matter of concern because we generally are reasonably conservative with regard to biologicals. And we use it only when methotrexate fails.
Correct.
We are not that aggressive with biological. The reason is that the very long-term safety of biologicals in children is still a matter of concern.
Correct.
So we really don't know the safety over 20 years, 30 years after you have exposed the child to biologicals. Cost varies from
general cost?
Cost varies from biological to biological. So the commonest biological that we use is adalimumab, and so 40 milligram adalimumab costs somewhere around 6,500 to 7,000.
Very good. And once upon a time, that used to cost what?
Much more.
Much
more than this.
What about tocilizumab? Everyone knows about it since the COVID time. Use, misuse, whatever you call it.
Yeah, tocilizumab 80 milligram costs around 8,200. 200 milligram costs around 17,000.
Oh, wow.
So tocilizumab is mostly used in systemic JIA.
Right.
Cost is an issue.
Why is Anakinra somehow still missing from India?
Anakinra is made by a Swedish manufacturer. It's the only company which makes which manufactures and
extremely expensive.
It is expensive, but over the last 2 years or so, it has become more easily available. But we have only used it occasionally in children with very severe macrophage activation syndrome.
Correct. Dr. Sumobalan, you did mention about JAK inhibitors. So a word about what is those JAK inhibitors and where is this common use?
So again, in actually there are different indications in JIA. So polyarticular JIA, when they are methotrexate and DMARD inadequate or resistant, and again, enthesitis related arthritis. So this is a group in which it is a lot cheaper. Tofacetine is cheaper than using anti-TNF. So for the poorer patients, it's a good drug. It works.
And much safer?
Who have
much safer also?
Not necessarily. We have to be careful with the use actually.
Okay.
So there is a risk of increased infections of herpes zoster
Mhm.
being triggered. There is also many of these children do develop altered lipid profiles.
Okay.
We don't know what it does to them. I've not seen a complication related to that, but it's pretty
Mhm.
common for them
Correct.
to develop hypercholesterolemia on this.
Yeah.
Baricitinib is very expensive now.
Mhm.
It's gone back. We had it cheap during COVID time. Now it's very expensive. So
Mhm.
it's very, very limited, the use of that.
What about the last two? You did mention about sulfasalazine and what about leflunomide? These are drugs which are used anymore in
Yes.
children?
So sulfasalazine is indicated in the ERA-JIA group, and
Mhm.
it can be considered as an add-on drug in some of the polyarticular patients.
Okay.
But it's not really helpful. Say in systemic JIA, it's not a useful DMARD to use.
Okay.
Leflunomide is a useful add-on DMARD to
Mhm.
methotrexate in polyarticular or in systemic JIA.
Correct.
You do have to be wary about combined hepatotoxicity and monitor them closely when you do
Correct.
that.
So it is like a poor man's biologicals, you can say?
Yes, the combination. We also have thalidomide and lenalidomide that we
All
use
right.
for men's biological.
So I think we had an extensive and an extremely engrossing discussion on to start with what is not GIA but still joint issues. First 5 cases and the last 4 cases on the typical GIA, the oligoarticular, the polyarticular, the ERA related, and of course the SGIA or the systemic onset GIA. And I think excellent we have done. And just to remind the delegates before you leave that on the June 1st Thursday, we will again have a webinar on vaccines. Well, I thank you everyone for joining in and being with us till so late. And a special thanks to all the faculty today, especially Dr. Sujit Singh, Dr. Suma Balan, and Dr. Shikha Agarwal for making it a very lively discussion today. Over
Nitin bhai, just a minute.
to,
Dr. Jayant Upadhyay had asked one question. So,
okay.
Jayant bhai, please.
And please raise your hand and ask question.
Yeah, please.
Unmute, sir. Unmute.
I have already posted it in the chat. After using biologicals for the treatment, when the child lands up with remission, do you start with steroid or again you start with biologicals only? Surjit Singh, sir.
It depends on for which condition you have used biologics. But if the child has responded to biologics, for instance, if child has responded to tocilizumab and you're treating a systemic JIA, you would just taper off the biologics and stop it.
Yeah, you said that sometimes even after giving tocilizumab, after the child is remission, sometimes they land up with again they come up with the symptom. Then at this stage, what do you start?
In such a situation, yes, you're right. We would have to use steroids again and continue tocilizumab for longer periods.
I think, Jain, by what Dr. Sujit Singh trying to say that you'll have to individualize it. There's no one shoes fit all type of, depends on why the biologicals were given to start with, how well the response was, and then now what is the ongoing, and accordingly you will take. It's always a dynamic situation.
Yes.
Well, conclude, Dr. Ramesh Bajania, please.
Yes. Thank you, Nitin bhai, for really, really nice moderation, because pediatric rheumatology is the topic. I mean, as soon as general pediatricians, they hear the name, I mean, they simply are afraid, because it's a very, very complex, and all the 3 faculties, they made this topic such a lucid and clear, and very, very nice curating by Nitin bhai. Says he has brought out 9 cases and almost it covered most of the pediatric rheumatology. So thank you so much, Nitin bhai. Thank you so much, all the 3 dignitaries, all the 3 learned faculties, and the friends who graced the occasion today. And finally, Zydus for all the help, audiovisual help. So as Nitin bhai said, we'll meet again on 6th with vaccinology called the shorts. Right. So
thank you.
Thank
you. Good night, everyone.
Thank you so much.
Thank you once again, Sikha. Thank you, Deepa, man. Thank you, Sujit. Thank you.
Thank you. Good night.